Dr. Dieter told me that most of the participants would be students. So I changed my presentation and I made now a presentation for students. Yeah? So I apologize for professors. There will be a few slides for professors, but most will be for students. So it will be like something like a lecture. But let's start now with like this. We start always with a joke. Yeah. So look carefully at this slide, because you have to vote afterwards. So look at the slide, you see it is a study about falling asleep. Yeah. And falling asleep, yeah, when is it in class, at work, or in bed? Yeah. So think a moment which type of study we did to prove this. You think, and then we are going to vote. Yes? So who says this is a double-blind controlled trial? One? Yes, okay. Who says this is a single-blind controlled trial? Who says this is a case-control study? At least, yeah. Three people. But you followed, at least. Yeah. Now, there's something special also. I was sitting behind to listen to the first part of this Congress. And a lot of people were like this. So I thought, this is what my slide is about. They are sleeping. But then I saw they were not sleeping at all. They were all looking like this. All with the WhatsApp. So I propose people, the students who are here and who want to follow this course, yeah, this presentation, put this away just for a quarter of an hour and try to follow what I'm going to tell you. What's this now? Most of you do not know, so I thought it might be interesting for students also to know what has happened in the past. So in the 80s, Sackett started to think about evidence-based medicine. And do you know what evidence-based medicine was at that moment? It was unbelievable. Students went to the library, they had a patient. So Sackett said, what are we going to do with the patient? So they went to the library, they got 2 or 3 copies of one or another article, then they sat together to discuss the value of the articles. So every student or assistant was supposed to understand research. And then they came together, they said, we think that this patient should get this or this treatment, and they treated him. After a while, this has changed. It changed to that guidelines were made not by assistants, but by experts. First in the hospital, and then... And now this morning, I learned from Professor Steve that actually this has changed again. It are not experts at the national level, some of these experts are here, but it is now by crowd and by machine learning. And that's unbelievable. Now the role of experts is finished, now the machines will take it over. It's not a joke, it's real. Instead of being forced as an assistant, because a lot of you are doing or will do a meta-analysis, instead of looking at all these thousands of articles, you just put them in the computer and a machine can tell you a lot before you come to conclusions. And that's very interesting. Thanks, Steve, to teach me that, yes. Oh, yeah, so we go for diagnosis. I have only 7 slides, so it will not take a long time, 7 slides with some explanations. So 7 simple, not so simple messages, but I think for students it's extremely interesting to follow what I'm going to show you. Yeah. So the first item is, first pitfall, is that still in a lot of publications, they give you the predictive value of a test. And since the 80s, Sackett said, never give predictive values of tests, diagnostic tests, in clinical context anymore. And here you can see why. Yeah. This is an HIV test. Yeah. Let's see if this works. Yeah. This is an HIV test, and you do this HIV test first in a prostitute who comes with weight loss, serious weight loss. You do an HIV test, this test is positive, and you see that you go from 10% of probability, you go to 90. Yeah. When you do this test before an operation, in everybody, in some hospitals they do it routine, you do it to an old lady, 70 years old, and the test is positive. But this lady did not have transfusion or operations or nothing at all, no sexual risk. Yeah. Then you see that you go from 1 in 100,000 to 1 in 1,000. Is this the same test? What is the value of this test? You might say, no, this test, the value of the test depends on the patient. You can't say that. A test should be independent. And that you can see in the next slide. Yes. The problem is that up until 20 years ago, they presented the results of a test on a classical scale from 0 to 100. The tests, finally, you should put them on a logarithmic scale. And here you see, this is, in the past, we thought that you should do the test when you are in the middle of probability. So don't start with the test. If you have a good test, you do it when you have already some evidence. And Sackett also, in his book, he promoted that. And that's a big error. A big error. So you should do, here you can see, apparently, in the old lady, the test makes no sense. It does not increase the probability. But in the prostitute, yes. So you say, yeah, let's do the test. Yeah. Now, on a logarithmic scale, you can see easily that this test, on whatever probability you do it, it's the same test with the same value. So predictive values should disappear. That's my first. Then there is a nice example. Yeah, I'm going to give you this example. So at a certain moment, we wanted to know if to determine CD4 count was useful to switch treatment of HIV. So we wanted, everywhere in the world, we wanted to explore that. So several authors, they presented their results, and they said, so the positive predictive value, the positive value of CD4 count for real failure is bad. Yeah. But they said, the negative predictive value is very high. So they went on to use this test. But it was an error, and I show you why. So they did the study in a cohort in which there were very few patients with virological failure. Look at this cell. When you start with only 1.7% of patients with a failure, and you do a very bad test, you will arrive finally at a very high negative predictive value. Why? Because before you do the test, your negative predictive value also is very low. You understand? It's very strange here. Without doing the test, what is the probability that your patient does not have virological failure? 98%. 8.3, because there are almost no patients with failure. You do a very bad test, yeah, and you arrive at almost the same. And then they publish, and I wrote several letters to the Lancet, to New England, and so on. I wrote letters to say, this is a big error. Negative predictive value with a bad test and with the low numbers of patients, it will always be very high. So you should stop to do these tests. But it took years before they stopped to rely on CD4 counts for switching the treatment. So when you see this on a scale, you do the test. Yeah, here pardon. You do the test, and the effect of the test is zero. But you can still say yes, there are very few patients, so the negative predictive value is high. Yeah. That's a nice. Now something more difficult is we go for what is an odds ratio. So I think everybody of you has learned what an odds ratio is. Most of you will be able to give me the formula. So most of the students know it by heart, I think. But nobody understands. I asked it several times to even professors, explain me what an odds ratio is, just in one sentence. They said, no, I can give you the formula. I said, no formula. Give me the meaning. Very difficult, yes. So what is an odds ratio? An odds ratio gives you the conforming power and the excluding power together. So what is the discriminative value of my test? If it's positive, it's good. If it's negative, it's good. So together, it's excellent. So that is odds ratio. But now look what happens. From time to time, you can have an odds ratio that's very high, not because of the fact that it confirms, but it's very high because it excludes. Yeah? And in that sense, you should use this odds ratio only to exclude, because it does not help you to confirm. And in a lot of studies, they use the odds ratio, which comes out of your multivariable analysis, they use it in a scoring system as a positive sign. In this odds ratio, as you have seen here, the positive power is almost nothing. It has got a high negative power. And so now I have something for the professors amongst you. How do we solve this? So students, you can sleep now, but the professors should follow now. Yeah. So how do you do? It's very simple. You replace the yes and no by the likelihood ratio in univariable, and then you do your analysis. So very, very simple for the professors amongst us. Yes. We go for number 4. Number 4 is something quite simple. Let's speak about appendicitis. You are interested in appendicitis and you want to know what the value is of, for instance, clinical examination, of questioning the patient. You go to the literature, and what do you find? The value of your anamnesis, your history taking, or your clinical examination is nothing. Look, you can see it. Yeah? This is from the literature, from a meta-analysis, where you can see that the values, look, even guarding, which is very important, I find, a very important sign, the value is almost nothing. Almost nothing. How can we explain that? Because that's, you might say, we clinicians, we should do nothing, we just go for a CT scan. Because our questioning is useless. Yeah? So we go for a CT scan. How can we explain that? Yeah. We can explain that by this. Yeah. Let me show you. If you do research, now we go to really fundamental research. You do research, you have a group of patients with heart failure, you have a group of patients without heart failure. Yes? Next, you look, what's this? Yeah, this. And now, within your patients, you will have patients with edema and patients without edema. So we have 4 groups. You all know this, but follow well because it's easier. Yeah. If you do this, you research in a ward here in Saggito, in a ward of geriatrics. Yeah. What will you find? You will find that a lot of patients in geriatrics without heart failure, they will also have edema. Edema by venous problems, etc. But if a lot of other patients also have edema, your edema is worthless. You can do nothing with that. But if you are in private consultation or you are in a health center, there are people with edema, they are quite rare. So in the health center or in your private consultation, edema is a good sign. What is the problem? The problem is that a lot of research is not done in the setting where it is aimed at. A lot of research is done in pediatric university services. You can do some research there, but never say that the results of that research you will use somewhere in a health center. And because of this, because of the fact that the sampling you do is completely erroneous. In appendicitis, so the case I've shown you, the meta-analysis, the results, they come mostly of services of abdominal surgery. There, everybody in emergency of abdominal surgery, a lot of patients have guarding. So it cannot distinguish between patients with appendicitis and other patients. So this up to diagnosis. So let's take 2 more for therapy now. Most of you do not know when evidence-based medicine started. It really started in the years 40 and 50 of last century. And there is one unbelievable example also of not following what comes out of research. At the end of World War II, the Americans vaccinated a lot of recruits for yellow fever. They vaccinated them, but the vaccine was contaminated with hepatitis B. So they could then do a nice study, 3 groups, a group with a diet, a group with the rest, and a group with normal activity. What did they see? Rest did not make sense. Diet did not make sense. They just could say to the patients, do what you want, eat what you want. Well, it took 50 years in Belgium to convince GPs, general practitioners, not to prescribe rest to their patients or diet to their patients with hepatitis. 50 years. So we can do some nice research, but to implement that to the results in the reality, often it takes a lot of time. Another one is myocardial infarction. When I started as a youngster, as an assistant or a student like you, someone with a myocardial infarction, what did we do? 1 month in bed. 1 month in bed. And then 5 months, no work anymore. So these people, they just, a lot of them, when they were in bed, they got pulmonary embolism, so they already died. Then of the other ones, 5 months without work, a lot got depressed. You had suicides and so on. It was terrible. And now, someone with a myocardial infarction, next day or 3 days later, he is on a bicycle already doing exercises. Also, this took years and years before we could convince clinicians not to prescribe them to rest. 5 minutes. I know, I see. It's almost finished. There's a nice example also in therapy that you should know, and you should be aware of that. That is, when someone in Belgium traveled and he comes back with dengue fever, then they say you should never travel again to Indonesia or to Asia or the Caribbean. Because if you travel, if you get another infection, your mortality will be 100% higher. So the patient already, they shiver like that, yes, and they never travel again until they come and see us. We calculate that, yes. So, and that's true. The risk, if you are infected with another strain, the risk, the mortality is 100% higher. So double. Yeah. So then, what did we do? We calculate that nicely. Look. So, what is the probability that they get another time a dengue infection when they travel? 1%. What is the probability of to get a serious? Yeah, that's 2% of the 1%. And then, what is the mortality of a serious dengue? 1% of the serious dengue. Yeah. And then the probability to get another strain is 1 in 4. So finally, the risk of these travelers, when they go back, to die of dengue is 1 in 2 million. 1 in 2 million. And it's double now, because of the other strain, so it will become from 1 in 2 million, 1 in a million. So the risk of dying by a traffic accident is 1 in 3,000 or something like that. So when people say, can we travel, can we go back to Indonesia or so, then we say, yes, but put on your safety belt in the car. Yeah, that is the lesson from the dengue. Yes. I will skip the last one, this guideline, because that's quite difficult. And let me show you the last one, and that is not a pitfall, but an unbelievable scandal, yes. Because we say we should go from evidence and then put it in practice. So there is, in research, we learned how to replace a genome, to do something, yes. If something is wrong in a chromosome, how to repair that, yes. So normally, for a new drug treatment, we say, what might be the price of increasing the length of living by 1 year? So that is a good living. So that's one quality. Yeah. So in every country, you have an amount of money you could spend. Yeah. In Belgium, for instance, it's 70,000 euro, more or less, that you can spend, especially in cancer patients and so on, for 1 year. So what did they do now? There was this child, 6 months old, with a muscle disease. So they invented a treatment for this disease. So it was a big scandal in Belgium. What did they ask for this? It is only one injection. Only one injection. Only one injection, 1.7 million euro for that. So in Europia, I tried to figure it out. It's, I think, 25 billion rupiah for one shot, one injection. Yes. So when you go from, and how do they calculate that? They say, yes, but that child now, the child can live now for perhaps 20 or 30 years. So we multiply that by 70,000, and so you come there. So it's crazy. It's unbelievable, yes. One injection, 25 billion rupiah. And that is evidence-based medicine. Yes, you come from evidence. Yeah, this drug is effective. Yes, And then you go to reality, how we apply this drug, and then you come to these unbelievable effects. So this is not a good example of evidence, of applying evidence-based medicine. So I think that we can stop here and terima kasih.